If you are 30 or older and have not had a complete cholesterol screening recently, new guidelines from the most authoritative cardiovascular medicine organizations in the world say you should. And if you are in that age range with elevated LDL cholesterol that has not responded adequately to diet and lifestyle changes, those same organizations are now recommending that medication be considered earlier than previous guidelines indicated. The American Heart Association, the American College of Cardiology, and 9 other leading medical organizations jointly issued updated lipid management guidelines in March 2026, published simultaneously in the journals JACC and Circulation. The changes represent a meaningful shift in how cardiovascular risk is assessed and managed, particularly for younger adults who have historically been undertreated. Here is what changed, why it changed, and what it means for you. The most significant new recommendation is the Lp(a) test. Lipoprotein A, written as Lp(a), is a specific type of lipoprotein particle in the blood that is genetically determined. Unlike LDL cholesterol, which is significantly influenced by diet and lifestyle, Lp(a) levels are primarily set by your genetics and remain relatively stable throughout your life. High Lp(a) is an independent risk factor for heart attack and stroke, meaning it raises your risk regardless of what your regular LDL level looks like. The higher your Lp(a), the greater your long-term cardiovascular risk. The updated guidelines now state that Lp(a) should be measured at least once in every adult's lifetime. This is a new addition to standard cardiovascular screening. Lp(a) is measured through the same blood draw as a regular cholesterol panel, but it requires a specific test order that was not previously part of routine guidelines for most adults. Many people who are walking around with high Lp(a) and therefore elevated cardiovascular risk have never been tested for it because no one ordered the test. Why does this matter at age 30 specifically? Because cardiovascular disease is a decades-long process. The arterial plaques that cause heart attacks and strokes in people's 50s, 60s, and 70s often began accumulating in their 30s and 40s. Identifying elevated Lp(a) and elevated LDL early in adulthood allows for a longer intervention window. Lower LDL for a longer period of time produces significantly greater protection against heart attack and stroke than the same LDL reduction started later. The earlier the risk is identified, the more years of protection any given intervention can provide. This is the principle underlying the second major change in the guidelines: earlier pharmacological treatment for LDL. The updated recommendations state that for adults as young as 30, whose LDL cholesterol remains elevated after a genuine period of dietary and lifestyle optimization, medication to lower LDL should be considered. Previous guidelines tended to reserve medication discussions for older age groups or for people with established cardiovascular disease or diabetes. The new guidelines shift that conversation to younger adults who are currently healthy but whose LDL trajectory suggests accumulating risk. The guideline committee chair, Dr. Roger Blumenthal, framed the reasoning clearly. While lifestyle optimization remains the first step, if lipid numbers are not within a desirable range after a meaningful period of lifestyle changes, adding lipid-lowering medication earlier than clinicians might have done a decade ago produces greater long-term protection. The biology is clear on this. Lower LDL for a longer time produces a compounding protective effect on arteries that reduces cardiovascular risk substantially more than the same reduction achieved later in life. Statin medications remain the foundational treatment for elevated LDL according to the guidelines. Statins reduce the liver's production of LDL cholesterol and increase the number of LDL receptors that clear LDL from the blood. Decades of clinical trial data confirm their effectiveness and safety profile. For people whose LDL does not reach target levels on statins alone, the updated guidelines recommend considering non-statin therapies as additions rather than waiting or accepting inadequately controlled LDL. What are the target LDL levels the guidelines recommend? For people at borderline or intermediate cardiovascular risk, the target is LDL below 100 milligrams per deciliter. For people at high risk, meaning those with multiple risk factors, established cardiovascular disease, or conditions like diabetes, the target is below 70 milligrams per deciliter. These targets are not new, but the willingness to pursue them with medication at younger ages than previously recommended is. The broader context for these guideline updates is a shift in understanding about when cardiovascular disease actually begins and how much of its development happens silently before symptoms appear. Heart disease is not primarily a disease of old age. It is a disease that starts in young adulthood and becomes symptomatic in middle age and beyond. The plaque accumulation, arterial stiffening, and endothelial damage that eventually cause heart attacks and strokes begin during the decades when most people feel entirely healthy and consider cardiovascular disease a distant concern. Population data on early-onset heart disease has been pointing in a concerning direction. Heart attacks and serious cardiovascular events in adults in their 30s and 40s have been increasing as a proportion of total cardiovascular events, driven by rising rates of obesity, metabolic syndrome, diabetes, and sedentary lifestyle in younger age groups. Against this backdrop, the decision by 11 major medical organizations to extend their screening and treatment recommendations down to age 30 reflects both the science on early-stage disease accumulation and epidemiological trends showing that the previous approach was leaving younger adults inadequately assessed. For people who have not had a complete lipid panel, including LPA, in the past few years, the practical action is to schedule one with a primary care physician. The test is a simple blood draw that can be done at the same time as any other routine blood work. Knowing your LPA once in adulthood, your LDL level, your HDL level, and your triglycerides gives you and your doctor the information needed to make accurate decisions about your cardiovascular risk and what, if anything, needs to change. Cardiovascular disease remains the leading cause of death globally. The shift in these guidelines reflects an updated understanding that protecting against it requires action that starts earlier than medicine has historically prioritized. New videos every day covering the medical guidelines and health decisions that actually affect your long-term outcomes. Subscribe and stay with us. The LPA finding specifically deserves further emphasis because it represents information that most people in the relevant age groups have never been given. High LPA is present in approximately 20% of the population. It cannot be meaningfully lowered through diet or lifestyle changes. It does not respond to statins the way LDL does. It is a genetic risk factor that requires different management strategies, including more aggressive LDL reduction to compensate for the added LPA risk, potentially aspirin therapy in appropriate patients, and heightened monitoring. None of these management decisions can be made without knowing the number. And until these guidelines were updated, most adults under 50 without a family history of very early heart disease would never have been tested. Asking your doctor to include LPA in your next blood panel is a simple action with potentially significant informational value. The test adds minimal cost and no additional clinical burden. If your LPA is low, you have useful reassurance. If it is high, you and your doctor can factor it into your cardiovascular risk assessment and management plan in ways that were previously not being done because the measurement was simply not there. The broader message from these updated guidelines is that cardiovascular health is not something to address reactively after a concerning event. It is something to monitor, understand, and manage proactively, starting in the third decade of life when the protective window is longest and the intervention options are most numerous.